Our final speaker this morning is Jae Moon Lee, who's assistant professor of surgery here at UCLA and member of the cardiothoracic surgery division. Jay, while Jay's setting up his slides, I'm going to introduce what he's here to talk about. Jay, as you know, as I mentioned, is a surgeon. And not everything in the esophagus responds to medical therapy. As Raman pointed out, there are certainly options for treating Barrett's or its complications. And there are situations in which patients with reflux symptomatology may or may not be adequately controlled with medical therapy, or may choose at times what might appear to be a more permanent fix than to maintain medical therapy. So to talk about treatment, surgical treatment in GERD and Barrett's, Jae Moon Lee.
Thank you very much for coming to UCLA this morning. My talk is on the surgical aspects of both reflux and Barrett's esophagus. I'm not going to go into all the details of GERD, but these are the basic indications for surgery, some of which are controversial, others which are more straightforward. I think the majority of patients are going to be adequately treated by medical treatment alone, but there are clearly some patients that have GI indications and non-GI indications that may benefit from surgical intervention. Unresponsiveness to optimal medical therapy, this includes both the use of proton pump inhibitors as well as lifestyle changes, non-compliance with medical therapy, high volume reflux. These patients, one has to consider the presence of a paraesophageal hernia where the stomach can migrate into the chest, severe esophagitis on endoscopy, complications related to reflux disease such as stricturing or Barrett's esophagus. The role of surgery in non-GI symptomatology is more controversial, and there's really no real consensus on this. Patients with laryngeal disease and asthma patients are included in this group. About half of patients with reflux disease will have some component of upper respiratory symptoms, and these things include hoarseness of voice, laryngitis, wheezing, nocturnal asthma. This is something that occurs at nighttime, coughing, aspiration, and dental erosion. Now, most of these patients that present, some may benefit from surgical fundoplication, and it's hard to predict who will actually respond. In some of the studies, if the presence of the typical reflux symptoms, which are up here, as well as the presence of respiratory symptoms, they tend to have a better response and benefit to surgery. Preoperative evaluation, it's important to make the diagnosis, pH monitoring for 24 hours, esophageal manometry to assess the intrinsic function of the esophagus itself, endoscopy to make sure there's no underlying other issues such as cancer, and also to assess the severity of the situation. Some other optional workup that may be included is a barium esophagram to look at esophageal shortening. With chronic inflammation and irritation of the esophagus from the gastric secretions, the esophagus can shorten due to a scarring effect. A gastric emptying study to assess for how well does the stomach empty, and finally impedance study to look at non-acid reflux or bile reflux. All of these studies impact how one would approach the surgery for a fundoplication. There is no one best operation for all patients, but these are the factors that we consider surgically. Is there a component of esophageal shortening? Disturbances in esophageal motility. If the esophagus doesn't work very well, then creating a rep or a fundoplication for it to move food and liquids across becomes harder. Prior operations, whether in the chest or in the abdomen, will dictate the approach to the surgery itself, and also the training and the expertise of the surgeon. For the most part, laparoscopic Nissen fundoplication, which is a minimally invasive approach to use the use of cameras and minimally invasive techniques in the abdomen, This operation is ideal for patients with a normal esophageal length, so patients without esophageal shortening, and with normal motility. There have been numerous studies that have looked at the advantages of a minimally invasive approach compared to open surgery with laparotomy. In this one study, it evaluated 12 prospective trials. There was a 65% reduction in complication rates with the minimally invasive or laparoscopic approach. Faster recovery, patients left the hospital about 3 days earlier, a quicker return to work, approximately 8 days earlier, similar treatment outcomes or failures, but laparoscopic surgery was associated with a higher reoperation rate, 79% higher reoperation, and a longer operating time of 39 minutes. So what is laparoscopic fundoplication? Well, this is a patient here that is laying down, the head's here and the feet's down here. We generally make 5 ports. It requires general anesthesia. We insufflate gas into the abdomen and creating what we call a pneumoperitoneum. We dissect out the esophagus. This is the liver here. Esophagus coming down from the chest into the abdomen. This is the diaphragmatic hiatus. It's an opening in the diaphragm. Often there is a widening or a hernial defect in the diaphragm, as well as this is the presence of the stomach here. So we dissect out the esophagus right at its entryway into the belly. We close the diaphragm posteriorly on the back side. So the patient's front is here, and this is the patient's back. So the esophagus is coming in, turning into the stomach here, and we close the back portion of the diaphragm, what we call crural closure. And then we create a wrap. We take the fundus of the stomach, which is this portion of the stomach, take it behind the esophagus, bring it around, creating a fundoplication or a wrap, and then we suture those 2 ends together so it creates a barrier for the gastric secretions from going up into the chest. And this is what we call a wrap or a fundoplication. The complication rates are low. These are wrap herniation is where the fundoplication migrates back up into the chest. It occurs about 1.3% of the time, and all the other complication rates are fairly low, under 1%. Pneumothorax is air in the chest. Perforation is where you injure one of the organs. Bleeding, pneumonias, infection. The trocar is what we use to insert into the abdominal wall. You can get a hernia at that site, and again, 0.2%. Blood clot to the lungs, injury to the spleen, and then heart attacks. So all the risks for the most part are pretty low. Now, most patients are going to have are fairly satisfied with the results of the surgery. At 10-year follow-up, 95% of the patients are fairly happy. However, surgery is surgery. There are clear downsides and risks and complications and long-term sequelae. 5 to 10% of patients will need some type of revisional surgery because of recurrent symptoms, and these are mainly due to recurrent reflux or dysphagia. Dysphagia is difficulty swallowing. So you eat or drink something and you have a difficult time swallowing that down and moving that down. 10% of patients that 10% of the patients that actually undergo the revisional surgery will continue to have these symptoms and will not benefit from the revisional surgery. And then some of the long-term side effects from fundoplication. Most patients benefit. However, there is a component of dysphagia. 8% of patients will have dysphagia, difficulty swallowing. We create a wrap, a functional barrier, and it's more difficult to swallow across that. This is particularly important to make sure that patients don't have an underlying esophageal motility problem where they can't contract very well, because if we create a tight wrap, it's going to be even more pronounced that they have more difficulty swallowing. Abdominal bloating. This is a sensation of a need to belch or burp, but you can't quite do that. So 10% of patients will have abdominal bloating. Patients that have delayed gastric emptying will particularly have pronounced effects from this, so one has to consider that. Nuance of diarrhea occurs in about 14% of patients. So some of the surgical considerations that the surgeon has to think about are the degree of the wrap, the degree of the fundoplication. There's a complete wrap, which is a 360-degree wrap around the esophagus by the stomach. It provides greater long-term durability and better results. However, there is also a partial wrap, which is less than 360 degrees, and there's various surgical modifications of how one creates a partial fundoplication. Patients have less postoperative dysphagia or difficulty swallowing. This is particularly important for patients with primary underlying esophageal dysmotility. So it's important to get the esophageal manometry prior to surgery. Shortened esophagus, again, is because of chronic inflammation, irritation of reflux into the esophagus that causes the esophagus to get shorter. This shortening process can lead to herniation of contents of the stomach or other organs into the chest. But a shortened esophagus creates a technical issue because if you create a rep, that rep will just migrate up into the chest and the patient will continue to have symptoms after surgery. So this has to be considered prior to surgery. Now, surgically what we can do is what's called a Collis gastroplasty. This is the esophagus turning into the stomach and then to the rest of the GI tract. And what we do is we lengthen the esophagus by taking a stapler and creating a longer esophagus by cutting into the stomach, and then this lengthens the esophagus here, and then this portion of the stomach is then wrapped around the esophagus, functionally creating a fundoplication and lengthening the esophagus. So this is called a Collis gastroplasty, and it's combined with the standard fundoplication approaches, whether it's done through the abdomen or through the chest. Sometimes it's more advantageous to do these operations through the chest, and the times that occurs is when there's concurrent lung disease that one has to address, or extensive abdominal surgery, so we want to avoid the abdomen and prefer the chest. In cases of periesophageal hernia where this occurs together, then and there's a lot of abdominal organ herniation, then it's preferable to go through the chest. So, in summary, for reflux, anti-reflux surgery, I think most patients will be controlled quite well with medical therapy, but clearly there's a subset of patients that can benefit from surgery. And these tend to be patients that are refractory to medical therapy. The few patients that are actually intolerant of proton pump inhibitors, and patients that develop complications from reflux disease, such as strictures. There's no best one anti-reflux operation for all patients. I think for the most part, laparoscopic Nissen fundoplication is the operation of choice, but the patient's got to have normal esophageal length, no shortening, and normal functioning motility. Surgery overall has a low complication rate, but has some clear long-term side effects in a minority of patients, somewhere around 10% of those patients, and we went through all of those issues. And most patients are satisfied with the anti-reflux surgery, but there has to be some considerations made in terms of the approach, and that includes the esophageal shortening issue, esophageal dysmotility issues, prior operations, underlying chest disease, and the expertise of the surgeon. So that covers reflux disease and what we do surgically for reflux disease. The other topic today is about Barrett's esophagus, and I'm going to focus on the high-grade dysplasia component because this is where I think the surgery has a more relevant role. So esophageal cancer develops, and this has been discussed several times. You have the lining of the esophagus is normal, and with chronic irritation from the reflux, you develop irritation, what we call inflammation or esophagitis. That causes changes to the lining in response to the irritation. We call that metaplasia. That metaplasia then goes through these changes that are in transition to develop cancer. We call this dysplasia. And the more aggressive or meaner it looks under the microscope, we say it's high grade, and if it's less aggressive, we call it low grade. Well, ultimately, this leads to invasive adenocarcinoma or esophageal cancer. So Barrett's esophagus that develops into high-grade dysplasia is a cancer. It's an intraepithelial cancer because there's a high incidence of high-grade dysplasia with invasive cancer. Now, this depends on how the biopsies and how meticulous the biopsies are done, but overall, you heard about issues with physician compliance in terms of biopsies to detect low-grade to high-grade. Well, the same issues apply for detecting high-grade to invasive cancer. How often do we pick up both? But the fact is that it's such close in transition from high grade to cancer, there's a high incidence that the two of them occur together. The management options you heard about, there's endoscopic techniques to ablate or to resect endoscopically, and then surgically to do a esophagectomy, which is to cut the esophagus out. So the issues surrounding this field is, one, it's an evolution. Traditionally, surgery was the answer and the gold standard for high-grade dysplasia. However, it carries a high complication rate and acceptable mortality in high-volume centers, but clearly it is a tour de force treatment, and so less invasive techniques are coming into a more defined role for superficial cancers. So if this is a schematic depiction of the esophageal wall. This is the lumen of the esophagus, where food travels through. This is the lining of the esophagus, and then there are all these layers. The involvement, the degree of which layer is involved is what determines the stage of your cancer. So high-grade dysplasia is a very superficial phenomenon, but along with that, the conversion to cancer is high, or they occur together fairly frequently. The importance of detecting cancer and figuring out what stage it is in the layer is because depending on the degree of involvement of the layer itself, it determines if the cancer spreads elsewhere, particularly the lymph nodes. In surgically resected patients, in a study of over 7,000 patients that underwent surgical resection for esophageal cancer for nearly a 30-year period, there's 35% incidence of lymph node metastasis if the lining of the submucosa, what we call the T1B layer, is actually involved by the cancer. So if 1 in 3 patients that have involvement of that layer have cancer that travels from the superficial layer down to the lymph nodes, then it's important to know if those patients have submucosal involvement or not. One of the downsides to the ablative therapies, as it's been pointed out, is that it does not provide tissue. It does not provide pathology. You don't take it out. We don't evaluate it. So we ablate it, we treat it, but we don't really know how involved it was in the layer itself. So from a surgical or oncologic perspective, that's a clear disadvantage. We don't have pathologic staging. Endoscopic mucosal resection does provide tissue. So what is evolving, what the current treatment is evolving into is ideally get pathologic tissue, because of the issue of sampling error with the biopsies. So if one can do an endoscopic mucosal resection and be confident that there's no submucosal involvement, then surgery may not be needed. On the other hand, if there's submucosal involvement and a third of the patients are going to have cancer that migrates to the lymph node, surgery is very much part of the oncologic treatment for that patient. Now, ablative therapies are now being combined with endoscopic mucosal resection as a combined modality, and the results are coming out on that as more and more experience is gained. So esophagectomy is taking the entire esophagus. So advantages of the surgical approach in patients with cancer that have a submucosal degree of early superficial cancer, and certainly the more advanced cancers, is it provides precise staging. We take the esophagus, we take all of the surrounding lymph nodes, we know exactly what stage is actually involved. It provides complete removal of the Barrett's mucosa that's at risk of malignant transformation, of it turning to cancer, particularly patients with long segment Barrett's and multiple areas of disease. The treatment is definitive. Yes, there's surveillance if there's cancer, but you don't need continued surveillance to watch for transformation of cancer. What are the disadvantages? It's a big operation. It carries substantial risk, and there is a risk of mortality, of death. Average hospital stay is about 10 days in large series. Substantial risk of major complications, particularly cardiac and pulmonary. Risk of perioperative death, about 2%, 2 to 3% in high volume centers, and that's been echoed in multiple studies. And there are some long-term effects with swallowing. It's not that patients can't swallow, but you no longer have the esophagus, and the stomach is used as a new esophagus, so it definitely impacts how one swallows. The minimally invasive esophagectomy, what we call MIE, is the approach that's used most often. It's not always possible. Depends on the degree of the disease and prior surgeries and if any other treatments were given. But MIE entails the use of thoracoscopy, which is making several portholes in the chest. This patient's head here, and feet's down here. We make several portholes in the chest and use cameras and long scopes to mobilize the esophagus in the chest. Laparoscopy often requires about 5 or 6 ports to access the abdomen to mobilize the esophagus. And now there's a development of robotic approaches for the mediastinal dissection, all to resect the esophagus and the surrounding lymph nodes. To give you a better idea of what it entails, well, this is the chest. Patient's head's here, abdomen, the feet are down here. Esophagus runs from the mouth across the chest and into the belly. The entire esophagus in the chest is mobilized and dissected out. And then we go into the abdomen. This is the diaphragm, which separates the chest from the belly. The liver normally sits here, so we're in the abdomen here. This is the stomach, and we cut out half of the stomach along with the entire esophagus. So it's really an esophageal gastrectomy, where we take the esophagus and half of the stomach out, leaving the outer portion of the stomach intact. We then bring up this outer portion of the stomach into the chest and connect it either in the chest or in the left neck. So then what it looks like is you have a connection from the little portion of the patient's native esophagus connected to the remainder of this stomach here, called, what we call this connection an anastomosis. And so there is no longer a functional stomach. The remainder of the stomach is now the new esophagus. So this is a major operation. So, but clearly there's a role for it in patients that have cancer. In summary, for Barrett's esophagus, the role of ablative and endoscopic therapies are quickly evolving and may obviate the need for surgical resection in very superficial esophageal cancers. But as I pointed out, it's important to understand what level of involvement there is in this superficial cancer. Esophagectomy is the gold standard for treatment of malignancies, particularly involvement of the submucosal layer and beyond. Esophagectomy does carry a high risk of complications, but a low risk of mortality or death in high-volume centers. Thank you.